Good morning, students. So today's topic of our lecture is cardiac efficiency test, CET. That's also known as exercise tolerance test. Exercise tolerance test. Exercise tolerance test. It is exercise testing and a non-invasive tool to evaluate the cardiovascular system's response to exercise under carefully controlled conditions. Exercise is the body's most common physiologic stress and it places major demands on the cardiopulmonary system. Thus, exercise can be considered the most practical test of cardiac perfusion and function. The exercise test complements the medical history and the physical examination, and it remains the second most commonly performed cardiologic procedure next to the routine ECG. Purposes of exercise testing. Exercise testing has been used for the provocation and identification of myocardial ischemia for 6 decades. Detection of coronary artery disease in patients with chest pain or chest discomfort syndromes or potential symptom equivalence. Evaluation of the anatomic and functional severity of CAD. Prediction of cardiovascular events and all-cause death. Evaluation of physical capacity and effort tolerance. Evaluation of exercise-related symptoms. Assessment of chronotropic competence, arrhythmias, and response to implanted device therapy. Assessment of the response to medical interventions. Types of exercise. There are 3 types of exercise which can be used to stress the cardiovascular system. They include isometric, dynamic, combination of 2. Isometric exercise, defined as constant muscular contraction without movement, such as hand grip, imposes a disproportionate pressure load on the left ventricle relative to the body's ability to support oxygen. Dynamic exercise, defined as rhythmic muscular activity resulting in movement, initiates a more appropriate increase in cardiac output and oxygen exchange. Exercise physiology. Sympathetic activation, parasympathetic withdrawal, vasoconstriction except in exercising muscles, cerebral circulation, coronary circulation. Increase norepinephrine and renin, increase oxygen extraction up to 3-fold. Increase ventricular contractibility, decrease in peripheral resistance, increase in SBP, MBP, and PP. DBP has no significant change, and pulmonary vascular bed can accommodate 6-fold CO, so CO increases 4 to 6 times. These are the graphs of the hemodynamic responses to dynamic exercise. Here you can have a look at the graph of heart rate, stroke, cardiac output, arterial pressure, total peripheral resistance, and oxygen consumption. Here is the metabolic equivalence, MET, which is known as metabolic equivalent term. 1 MET is equal to basal aerobic oxygen consumption to stay alive is equal to 3.5 ml oxygen per kg per minute. Clinically significant metabolic equivalents for maximum exercise. Here you can have a look. 1 MET is resting, 2 MET is level walking at 2 mph, 4 MET is level walking at 4 mph, above 5 mpts, poor prognosis, peak cost of basic activities of daily living, 10 METs, prognosis with medical therapy as good as coronary artery bypass surgery, unlikely to exhibit significant nuclear perfusion defects. 13 METs, excellent prognosis regardless of other exercise responses. 18 METs, elite endurance athletes. 20 METs, world-class athletes. Age predicted maximum HR includes age predicted maximum HR is equal to 220 of age in years. Targeted HR is equal to 85% of maximum predicted HR. Maximum HR decreases with the age. A high degree of variability exists among subjects of identical age, also not used as an indicator of maximum exertion in ETT, and indication to terminate the test. Here you can have a look at absolute contraindications. Acute myocardial infarction within 2 days, ongoing unstable angina, uncontrolled cardiac arrhythmia with hemodynamic compromise, active endocarditis, symptomatic severe aortic stenosis, decompensated heart failure, acute pulmonary embolism, pulmonary infarction or deep vein thrombosis, acute myocarditis or pericarditis, acute aortic dissection, physical disability that precludes safe and adequate testing. Here are the relative contraindications. Non-obstructive left main coronary artery stenosis, moderate to severe aortic stenosis with uncertain relation to symptoms, tachyarrhythmias with uncontrolled ventricular rates, acquired advanced or complete heart block, hypertrophic obstructive cardiomyopathy with severe resting gradients, recent stroke or transient ischemic attack, mental impairment with limited ability to cooperate, resting hypertension with systolic or diastolic blood pressures above 200 by 110 mmHg, uncorrected medical conditions such as significant anemia, important erythrolyte imbalance, and hyperthyroidism. There are methodology of exercise testing, safety precautions and equipments. Exercise testing appears safer today than it did 20 years ago. A treadmill should have front and side rails to help subjects steady themselves. It should be calibrated monthly. A defibrillators must be instantly available. A complete trolley of cardiac resuscitation equipment should be on hand, including intubation equipment and full range of cardiac drugs. Automate blood pressure measurement during exercise not recommended. The time-proven method of holding the subject's arm with a stethoscope placed over the brachial artery remains the most reliable. Here you can have a look at the picture of EKG. This is electrocardiogram recorded on machines. Here are the blood pressure curves. The patient is walking on a treadmill. Along with it, electrodes are connected to the machine, and some of the electrodes are attached to the chest. And you can see nurse is checking the blood pressure of the patient. Pre-test preparations. The patient should be instructed not to eat, drink, or smoke at least 2 hours prior to the test, and to come dressed for exercise, including proper footwear. The physician should also review the patient's medical history, making note of any conditions that can increase the risk of testing, the absolute and relative contraindications to exercise testing. A physical examination, including assessment of systolic murmurs, should be performed before all exercise tests. An echocardiogram should be considered prior to testing. Pre-test standard 12 lead ECGs are necessary. Good skin preparation is necessary for good conductance to avoid artifacts and is especially important for elderly patients who have a higher skin resistance and tendency forward contact noise. The areas of electrode application are first shaped and then rubbed with alcohol saturated gauge. Disposable electrodes used in exercise testing are generally silver chloride combinations with adherent gel. The changes caused by exercise electrode placement can be kept to a minimum by keeping the arm electrodes off the chest and placing them on the shoulders. Placing the ground electrode on the back out of cardiac field, placing the left leg electrodes below the umbilicus. Here you can have a look at the placement. Placement of the limb leads on the torso is necessary for reduction of noise in the ECG during exercise, whereas precordial lead placement is unchanged. Waveforms of activity compatible torso lead ECGs differ from those derived from standards. 12 leads to ECGs, but S3 segment shifts with torso electrodes are valid. The manubrial electrodes can be paired with standards lead V5 to produce bipolar CMF. From the figure, it can be seen that AVR, inverted AVR, using the torso electrodes positioned to produce the central terminal, has spatial orientation that is similar to the orientation to CM5. During the test, most complications can be avoided by measuring blood pressure, monitoring the ECG, questioning the patient about symptoms and the level of fatigue, and assessing appearance during the test. Subjects should be reminded not to grasp the front or side rails because this decreases the work performed and creates noise in the ECG. Target heart rates based on age should not be used to terminate the test because the relationship between maximal heart rate and age is poor. For test termination, the absolute and relative indications are used. Here you can have a look at indications for termination of exercise testing. Absolute indications. ST segment elevations and leads without pre-existing Q waves because of prior MI, drop in systolic blood pressure, despite an increase in workload when accompanied by any other evidence of ischemia. Moderate to severe angina, central nervous system symptoms, for example, ataxia, dizziness near syncope, signs of poor perfusion, including cyanosis or pallor, sustained ventricular tachycardia, or other arrhythmia, including second or third degree atrioventricular block that interferes with normal maintenance of cardiac output during exercise. Technical difficulties in monitoring the ECG or systolic blood pressure, the subject's request to stop. Here you can have like more indication of like relative indications, marked ST displacement, horizontal or downsloping of above 2 mm, measure 60 to 80 ms after the J point, the end of the QRS complex in a patient with suspected ischemia. Drop in systolic blood pressure above 10 mmHg persistently below baseline despite an increase in workload and the absence of other evidence of ischemia. Increasing chest pain, fatigue, shortness of breath, wheezing, leg cramps, or claudication. Arrhythmias other than sustained VT, including multifocal ectopy, ventricular triplet, supraventricular tachycardia, and brachyarrhythmias that have the potential to become more complex or to interfere with hemodynamic stability. Exaggerated hyperextensive response of systolic blood pressure and diastolic blood pressure. Development of bundle branch block that cannot immediately be distinguished from VT. You can have a look at during the test. If none of this endpoint is met, the test should be symptoms limited. The box scales are an excellent means of quantifying an individual's efforts. In general, a box scale rating above 80 indicates the patient has performed maximal exercise. Here is a box scale for rating perceived exertion. It is 20 grade scale. If it's up to 6 to 7, it's very light. It's 8 to 9, very light. 10 to 11 is fairly light. 12 to 13, somewhat hard. 14 to 15, it's hard. 17 to 18, very hard. And 19 to 20, very hard. You can have a look at the scale. To ensure the safety of exercise testing, the following list of the most dangerous circumstances in the exercise testing laboratory should be recognized. When patients exhibit ST segment elevation without baseline diagnostic QAs, this can be associated with dangerous arrhythmias and infarction. When a patient with an ischemic cardiomyopathy exhibits severe chest pain because of ischemia, angina pectoris, a cool down walk is advisable. When a patient develops exertional hypotension accompanied by ischemia, angina, or ST segment depression, or when it occurs in a patient with a history of congestive heart failure, cardiomyopathy, or recent MI, safety is a serious issue. When a patient with a history of sudden death or collapse during exercise develops premature ventricular depolarizations that become frequent, a cool down walk is advisable. Recovery after exercise. Monitoring should continue for at least 5 minutes after exercise or until change stabilizes. An abnormal response occurring only in the recovery period is neither unusual nor necessarily suggestive of a false positive result. The recovery period, particularly the third minute, is critical for SP analysis. ST depression at that times has important implications regarding the presence and severity of coronary artery disease. A cool down walk can be helpful in performing tests on patients with an established diagnosis undergoing testing for those other than diagnostic reasons, as in testing athletes or patients with congestive heart failure, valvular heart disease, or a reason. These are the exercise protocols: Bruce, Balkewer, Elastic, McHerney, Nocturne. The Bruce Protocol. In 1949, by Robert A. Bruce, considered the father of exercise physiology, published as a standardized protocol in 1963. Gold standard for detection of myocardial ischemia when risk stratification is necessary. Here are the most common protocols and their stages and the predicted oxygen cost of each stage. You can have a look at the chart. Here is the Bruce protocol. You can have a look at the stage. Stage 1, Stage 2, Stage 3, Stage 4, Stage 5, and Stage 6. Here you can have a look at the time of each stage per hours and the slopes. What represents a positive test? ST segment deviation. Changes in the level of the ST segment comprise the earliest abnormal finding in the history of exercise testing and have been the focus of standard test criteria for the diagnosis of myocardial ischemia for well over half a century. Here you can have a look at the pictures of the graph. This is ST segment deviation. ST segment depression. The standard criteria for test positivity include horizontal or downsloping ST depression above 1 mm at 60 to 80 ms after the J point. When the modest resting ST depression is present on the upright control, ECG before exercise, only additional ST depression during exercise is measured for analysis. In the presence of resting ST segment elevation at 60 to 80 ms after the J point, because of early repolarization, only ST segment changes below the PQ baseline should be used for analysis. The lower the workload and weight ratio product at which ST depression occurs, the worse is the prognosis and the more likely the presence of multi-vessels disease. The duration of ST depression in the recovery phase also can be related to the severity of CAD. This is ST segment depression during exercise. Definition of ST segment depression is the changes during exercise, position, standard twist. Responses include horizontal or down-sloping depression above 1 mm, whereas up-sloping ST depression above 1 mm is considered equivocal. All ST depression below 1 mm additional from baseline is defined as negative. The waveforms depicted are modified from travel with permission of the publisher. Here's the ST segment elevation in post-infarction patient with Q waves. Exercise-induced elevation can occur in an infarct area where prior Q waves are present. The development of above 0.10 MV of J point elevation at 60 ms after the J point is considered an abnormal response. In the presence of prior Q waves, MI, this could represent reversible ischemia in the peri-infarct area or ventricular dyskinesis or akinetic LV segmental wall motion. ST segment elevation in subjects without prior infection. In subjects without prior infection, absence of Q waves on the resting ECG, ST segments elevation during exercise frequently localizes the site of severe transient combined endocardial and subepicardial ischemia resulting from significant subtotal proximal occlusion CAD. Is the ST segment normalization. It is usual for young subjects with early repolarization to have normalization of resting ST segment elevation during exercise. Normalization of ST segment during exercise might be related to cancellation effects of oppositely directed forces from multiple areas of ischemic counterpose, which could be explained false negative test finding in some patients with multi-vessel CAD. Chest pain. Taken in association with ST depression, chest pain increases the sensitivity of the exercise test to approximately 85% in a cohort of symptomatic patients. The nature of the pain is important. Increase in R wave voltage. In the normal patient, R wave voltage decreases during exercise. Immediately after exercise, R wave voltage is at its smallest and then gradually returns to the normal during the recovery period. The reduction in R wave voltage is thought to be a result of the reduction of LVEDV with increasing exercise in the normal patient. In patients with coronary disease, airway voltage usually remains unchanged or increases, especially in those with poor LV function. Airway changes may be useful in patients with LPB, where ST changes lack sensitivity or specificity. Here you can have a look at abnormal systolic blood pressure response. Failure of the systolic blood pressure to rise during exercise is an important indicator of an abnormal LV and is an indication to stop the test. A decrease in systolic blood pressure during exercise is even more specific for severe coronary artery diseases, assuming that there are no valve lesions and the patient is not vasodilators. Development of ventricular arrhythmias. You can have a look at the 3 points: ventricular ectopics, multifocal ectopics, ventricular tachycardia, etc., associated with ST segment depression, and the chest pain, no more specific. Summary of variables developing during an exercise test suggestive of multiple vessel coronary disease and poorer prognosis. Chest depression at low heart rate, above 2 mm and several leads, downsloping, persisting above 5 minutes into the recovery period, blood pressure response, failure to rise or falling above 10 mmHg, ventricular arrhythmias developing at low exercise load, poor exercise tolerance, inability to complete Bruce protocol stage 2 or equivalents, and a positive test with an inappropriate tachycardia. Patients with these results are generally referred for coronary angiography. Here is the false positive results: hyperventilations, prolapsing mitral valves, hypertrophic cardiomyopathy, dilated cardiomyopathy, hypertension with LV hypertrophy, LBB, aortic stenosis. Young women with chest pain, Wolff Parkinson's, White syndrome, drugs, for example, digoxin, antidepressants, anemia, coronary artery, hypokalemia, hypersensitivity to catecholamines, and observer variability. Here's the exercise electrocardiographic test report. The exercise test report should describe information relevant to diagnose and prognosis. This would include the reason for terminating exercise, such as fatigue, more specific symptoms like angina, leg pain, or dyspnea, or a sign like drop in systolic blood pressure or arrhythmia. Resting, exercise, and recovery HRs and blood pressure should be tabulated according to stages, and peak exercise values should be stated. There should be a specific statement with regard to the presence or absence of chest pain at peak exercise and whether this was the reason for termination of the test. Patient effort can be defined by percent maximum predicted HRHF or by use of a chronotropic index. Additionally, it is useful to describe effort's capacity as percent of maximum predicted MET workload equivalents adjusted for age or and for sex. Peak and exercise or recovery phase as to segment deviation should be described, and the test should be defined as positive, negative, or equivocal according to the standards ST segment criteria. Here you can have a look at prognostic utilization of exercise testing. The two principal reasons for estimating prognosis are to provide accurate answers to patients' questions regarding the probable outcome of their illness and to identify those patients in whom interventions might improve the outcomes. This assessment should always include calculation of a properly designed score such as the Duke treadmill score or the VA treadmill score. Duke treadmill score. Duke score, exercise time in minutes, that's fine to ST depression mm minus 4 into angina index. Here you can have a look at angina index. At 0, no angina. At 1, non-limiting angina. And at 2, if angina stops test. At high risk, you can have a look at minus 11 mortality. And at low risk, it is plus 5. Here you can have a look at chart of age and double product adjusted Duke treadmill score, nomogram for prediction of cardiovascular mortality. You can have a look at ST segment deviation during the exercise. Here is the ischemia reading line. Angina during exercise, whether it can be known, non-limiting or exercise limiting. Average annual CV mortality, age reading line. Here this is adjusted DTAs. And second last, you can see that average annual CV mortality and last double product reserves. That's DT. You can have a look at this chart. The sample nomogram shows that the result of exercise testing in a 55-year-old male sheet metal workers with a typical chest pain. The patient reached 7 METs before the test was stopped because of exercise limiting angina. He had 2 mm of horizontal ST segment depression at maximum exercise. The predicted cardiovascular mortality for this patient is 4.5%, which is high. Catheterization is the appropriate next step. Here's the exercise testing after myocardial infarction. Benefits of exercise testing post myocardial infarction. Pre-discharge sum maximal test. Optimizing discharge, alternating medical therapy, triaging for intensity of follow-up, first step in rehabilitation, assurance, encouragement, reassuring spouse, recognizing exercise, induced ischemia and dysrhythmias. Maximal test for return to normal activities that are determining limitations, prognostication, reassuring employers, determining level of disability, triaging for invasive studies, deciding on medications, exercise prescriptions, continued rehabilitation. Complications secondary to the exercise testing. The first is cardiac, which includes bradyarrhythmias, tachyarrhythmias, acute coronary syndromes, heart failures, hypotensions, syncope, and shock. And the last one is death. You can have a look at bradyarrhythmia. It is a cardiac condition, or it is slower than expected heart rate. In this condition, the heart rate gets slower, generally beating fewer than 60 beats per minute. And next one is tachyarrhythmia. Tachyarrhythmia is a rapid heartbeat that may be regular or irregular, but is out of proportion to the age and level of exertion or the activity. Next is acute coronary syndrome. It is the condition brought on by a sudden reduction or blockage of blood flow to the heart rate. And next is heart failure. It's the most common one. What is heart failure generally? It is a chronic condition in which the heart doesn't pump blood as well as it should. Heart failure can occur if the heart cannot pump systolic or diastolic adequately. And next we do have the term hypotension. Now what is hypotension? It is the low blood pressure which can cause fainting or dizziness because the brain doesn't receive enough blood. Here are some of the non-cardiac conditions also, which includes musculoskeletal trauma. Now, what is musculoskeletal trauma? It is an injury that affects the bones, muscles, ligaments, nerves, or tendons, resulting in the pain and are considered musculoskeletal injuries. While pain may be widespread and affect the entire body, it is often localized in the hands and wrists due to their high use of exposure. For example, sprain, strain, or the clear back pain, carpal tunnel syndrome. This all are the example. Next, it's include the soft tissue injury. The most common soft tissue injuries are muscle tendons and ligaments. Mostly soft tissue injured are muscles, tendons, and ligaments. These injuries often occurs during sports and exercise activities, but sometimes simple everyday activities can cause an injury, like sprain, strain, and contusions, as well as in tendinitis and bursitis. These are some of the common, most soft tissue injuries. And next is miscellaneous, which includes severe fatigue, sometimes persisting for days, dizziness, body aches, delayed feeling of illness. Thank you.